And welcome to the LACNETS meeting, our first meeting for 2018. We're here at UCLA today. Thank you everyone who came out in this pouring rain. We're actually having weather in LA. And thank you so much for everyone who's joining us online from around the world. We appreciate you being with us for today's presentation. I'm going to make a few announcements about what's coming up. Next month, February, we will be at Cedars-Sinai, and we're going to do an informal roundtable with Dr. Andrew Hendifar at Cedars. The date is February 13th, and it will be from noon to 2 p.m. in our usual room in the Lower Conference Center. And then March, we will be back here at UCLA with Dr. Raymond, who will be speaking on interventional therapies for NET patients. So please join us for that. And I want to give a nice plug for May, please. Remember, May 19th is going to be our annual conference, a full-day conference for patients and caregivers. And that will be here at UCLA. We'll be in Cobell Commons. And UCLA has been amazing to work with, and we thank them so much for this space and also for hosting the conference this year. A couple of other things. We have some really amazing resources in LA that are all completely complementary for patients and caregivers. One of them is through the cancer support community. And we have some of their brochures out front, their calendars, and also Tower Cancer Research Foundation. Both of these organizations offer free classes in terms of exercise and support. There's massage, Pilates, Reiki, and they're really worth checking out. They're a great resource right here in LA. So I'd like to introduce our speaker today. We're going to have two presentations. One is our first with Dr. Sadoughi, and then we're also going to hear from the patient navigators who were kind enough to join us today from UCLA. So Dr. Parisa Sadoughi is an anesthesiologist and specializes in pain management. She is with UCLA Medical Center. Her offices are out in Thousand Oaks. And her comprehensive approach to pain management includes lifestyle changes, physical therapy, behavioral medicine, medication, and interventional therapies. So please welcome Dr. Parisa Sadoughi.
As introduced, I'm Parisa Sadoughi. I'm one of the pain docs here at UCLA. I'm just going to be talking about basically pain management. It's pretty much in every situation, but I try to tailor it more to neuroendocrine tumors. I know you all probably know what neuroendocrine tumor is, but I had to do a little research as to exactly, what are the treatments and where it usually comes up, because it's sort of a much more broad tumor type. It's not a very specific type. There's many different types. So neuroendocrine tumors usually come from neuroendocrine cells. They're the cells that have migrated from the neural crest to the gut endoderm, and it's from multipotent stem cells. They can also be sometimes called carcinoid tumors, and they can be symptomatic or not symptomatic depending on whether they secrete any hormones or the size of them. And they may be undetected for many years without obvious signs. It's funny, I didn't realize that that's what my grandma had when she died. And she had it, according to the doctor, since she was 17. So after I read about it, I'm like, oh, this is what she had. And it's interesting. There's different types, as I said. They can be a group of clusters of different types, which are called MIN1 and 2. They could be in the skin cell, which is the Merkel cell carcinomas. It can be anywhere in the lung, small cell carcinoma, or it could be the poorly differentiated small cell typical lung carcinoid. And it could be something called pheochromocytoma, which for anesthesiologists is the biggest fear we have when we get a patient with pheochromocytoma. But the good thing is with medicine, we have learned to really manage it before they come to surgery, so we don't have all the things that could occur and go wrong. And then there's the gastroenteropancreatic neuroendocrine tumors. Now, where does the neuroendocrine tumor patient's pain usually come from? It could be from anything. It could be from the actual mass itself. Maybe it's pressing on some nerves. Maybe it just the actual mass can release certain visceral pain. It can come from the endocrine release. For example, if there are certain endocrines that are released, it can be painful, some of them. And then it could also come from the treatment, which I think is most of the times that I see the patients in clinic. Now, they can range anywhere from basically the esophagus down to the colon. The majority of the neuroendocrine tumors come in the GI system. And what is the treatment? First line is surgery if it's operable, because you want to remove that mass. And then after that, if let's say they removed it, there's still areas that they're wondering, or it's metastasized, or it's somewhere that you can't remove, radiation, and then chemotherapy, and then there's targeted therapy as well. All right, so treatment of pain. In my clinic, I pretty much have almost the same exact tier I go through, because most pains have a multi sort of origin to them. It's not a simple mechanical pain that we have. And unfortunately, with chronic pain, which is any pain more than 6 months, our body doesn't respond the way it should normally. So it starts becoming different, and not in a good way, unfortunately. The brain receptors start building new receptors that shouldn't be there. They don't function, they malfunction, they malfire. They cause you more pain from the pain, which shouldn't happen, but our bodies aren't meant to really tolerate chronic pain, I think. So here's the tier. It's a little different for tumor cases and patients, but the first thing you want to know is diagnose where the pain is coming from. So unless you diagnose it, you don't know what you're treating. But unfortunately, it's very hard to diagnose pain origin. I have patients that come and I'm 100% sure, oh, you know what? It's because of this. And then I have to stop myself because I've been wrong before. And I think most pain doctors will say the same thing. You treat it and they haven't gotten better. So you got to think of the second thing that could be causing it. And the third. Sometimes you never find the origin of pain and you just have to treat it as is. Now, this is the tier that's in many books. It's a little different in each practice. So it depends on which doctor you go to. It depends on each patient. There isn't really a standard for every patient. And that's what I think we all have to understand as physicians and patients, that there isn't a normal. If you have pain, whether it's because of cancer, whether it's because of other reasons, you just have to accept the fact there is no normal. So if you ask your doctor, is this normal, is this not normal, whatever answer they give you, it doesn't make sense because everyone's different. My level of pain is different than Lisa's. Lisa might get a headache and she just walks through it, and for me, I would be going crazy and I can't function. I would cry, I would sit, I would lay down, I would tell everybody how miserable I am. But most of the time, the treatment, I like to use medications that have the least amount of basically chronic issues with the use of it. And my favorites are anti-inflammatory now, only if you can. So what are anti-inflammatories? Aspirin was the original one, but we like to avoid aspirin because it can really thin your blood. Things that I like is ibuprofen, Aleve. There's the medication ones that are prescribed, which is meloxicam and Celebrex. But those are prescribed by physicians. Now, you have to be careful that when you take any anti-inflammatory, there's two things you really have to worry about. One is your kidneys. So if you have any kidney issues, please avoid these medications. The other thing is your stomach. And unfortunately, with either radiation chemotherapy or the endocrine-releasing tumors, you might have some GI issues. So you have to kind of avoid it. The second thing that I like, Tylenol doesn't really work well, to be honest with you, by itself for me. But I can say that whenever I take the two together, there's some synergic effect, and it does help. So I have a lot of patients that come to me and be like, Tylenol doesn't do anything. Give it a chance again with other medications. Alone, yes, it might not. But together with other medication, it actually can have a pretty good effect. Now, the last thing is my favorite one because it has almost zero side effects. Topicals, ice, heat. We all underestimate how powerful those two can be. Of course, I have some patients that tend to burn themselves with the ice. You got to be very careful. Ice and heat can burn your skin. But topical things like Salonpas, which now has lidocaine patch. I know a lot of people use lidocaine patches. Guess what? Most of them don't stick on, and the one that does is really expensive to get. But Salonpas came out with a lidocaine patch. It's not 5%, it's 4%, and it does pretty good. And it has menthol patches, which I love. Kind of distracts your mind from the pain itself. Our brain is only capable of a certain amount of input. So if you fool it by another input, it tends to not feel the pain as much, which brings me back to the next slide too. So whenever you have some sort of a stimulation, even touch, you tend to not perceive the pain as much because those touch receptors land in the same area of the brain as our pain receptors. Now, chronic pain is a different thing sometimes, but that's the usual. Tiger Balm, Bengay is also menthol. There's strong ones out there online. And I should probably not be advocating this, but if lidocaine patches work well for you and insurance isn't approving it, unfortunately or fortunately, you can actually get them on eBay. The best brand is Activist. So, speaking of fooling your brain, there's a thing called TENS unit. I'm sure some of you guys have seen it. It's these like electrodes. They look like you get a little dial that goes up. It only works when it's on. So yes, it doesn't work when you take it off, unfortunately. I wish there was some long-term improvement with it, but there isn't. The idea again behind it is that you fool your brain. The touch sensation fools your brain to not perceive that chronic pain receptors going and basically firing in your brain. It can't compete with it. And so the way it works is you basically dial it up until you get to the point where it's comfortable, but it's fooling your brain. It might not work, but it's worth trying it. You can get it again at Amazon for a cheap price. You look it up, look at the reviews, make sure they're legit. But doctors usually can give you prescriptions, and if insurance doesn't approve it, then there's other routes. Then there's physical therapy, which is one of my favorites. And then the last one, I don't know if you can tell, that's supposed to be bold, which is psychotherapy. Now, physical therapy is usually useful after treatment. So if your pain came on because of chemo and radiation, all of those medications and radiation really destroys our bodies. We're not meant to survive cancer. I'm glad we have found a way, but it wasn't supposed to be. Thank God medicine has advanced, that we have learned treatments. We're learning new treatments to be able to treat it, but our bodies don't function right after chemo and radiation because you build scar tissue. Your body's immune response changes. Your body's response to pain changes. Everything changes. So you have to accept it and learn ways to adapt to it. It's kind of a sad thing to say, but it's the reality. So physical therapy after radiation, where you get all these scar tissues, and chemotherapy makes you weak sometimes, that helps you to get back to sort of to the way you used to be, if that's what you need. Again, everyone's very different. Some people go through chemo and they're fine, but most of us aren't fortunate like that. So physical therapy is wonderful after your treatment is done, or even like while you're in the process, to just try to continue moving your body, getting some strength. Maybe they even do massages. They do the TENS unit at physical therapy. They teach you how to adapt to your new body. It's wonderful. Then psychotherapy. Whenever I bring up the subject of psychotherapy with my patients, I have to give them a heads up first. I say, listen, I know you are not crazy. I'm going to bring up a subject that's very sensitive, which is psychotherapy. Psychotherapy is not meant for crazy people. I go to therapy myself. I admit to it. I have no major issues. It's just little things in life that you want to just get out and talk about it. But psychotherapy is even better than therapy. It can reprogram your brain receptors. The way it works is there's things like cognitive behavior therapy, which is used sometimes for personality disorders, and it works. Sometimes it's used for depression, and it works. But there's also something called biofeedback. So I don't know about any of you guys. When I have a headache, I am not myself. I can't even think. I don't even know what someone's name is anymore because that pain takes over my brain. So the way to take control over that is to train your brain. It's kind of like meditation. If you know how to meditate, you probably don't need psychotherapy. But most of us cannot meditate because our brain goes in these little circles that we can't think. Psychotherapy teaches your brain to ignore whatever it is. So you learn basically biofeedback. I've seen it once. I wish I would have done, I should probably go and learn more about it. What it is you see your body's response to stress. Your heart rate goes up. Your temperature goes up, your blood pressure goes up. All of these things are bad for your body. It's cortisol. Yes, there is a good level of it, but anything more than that, it just affects your body in a bad way. So what psychotherapy does is it teaches you techniques to calm down your body back to the way it should be. And that's very important. It is not easy to go through any treatment for even simple pneumonia, or it's not that simple, I shouldn't say that, but things that are treated and there's no sequelae. Cancer is a much bigger deal to go through. It affects you emotionally, physically. It affects your relationship with your loved ones. They might not feel it, but then you feel guilty sometimes thinking, I don't want him to be suffering through this. And that just makes it even worse. So all of these are important to go through, to talk to someone, to learn how to adapt to it. Take your loved one with you. Go through it together. It makes you even stronger. So psychotherapy is wonderful. Okay, now we get to the second tier. So that's my favorite. First tier to me is what's my favorite. And that's things that really change us more than it changes the process, I think. Second tier are things that I prescribe, and unfortunately, sometimes I have to do it more often than I like because the pain is not well controlled. So, opioids are the first one, and I'm sure all of you guys have heard all these urgency and everything else that's happening with our healthcare about opioids and how bad and horrible they are. Yes, they're horrible, but are they sometimes needed? Yes. So I get some patients that come to the office and they're going through something acute, which is that, like, the new onset, something that's going on, new something. And they're like, I just don't want to take anything. I love that my patients say that. That shows how strongly opinion they are about not wanting to take these medications. But sometimes it's okay. You can take it for a while until you get to a good place where you can come down. There's a big difference between just taking it every 2 hours or whatever it is, but then if you need it here and there, or if you need it daily for a certain amount of time, that's okay. And I'll go over the side effects and problems with it. Then the second component is neuropathic medications, which I'll go over, and then there's procedures. I'm going to go over all these in detail. This was just like the front. All right. Again, opioids, short term, it's okay. Don't worry about it. You can take it. Your doctors are already aware of it. Your pharmacies are really aware of it. Unfortunately, all of us are being very careful. Fortunately or unfortunately, I'm not sure which one. We're being very careful because of all the epidemic issues that's going on with it. And trust me, it's like so hard for me to give that prescription to patients because that goes on my record of the other opioid that I've given. But when my patient needs it, I'm more than happy to do it. Now, what long-term, the issue with that is tolerance, dependence, addiction, and side effects. If I could have, $100 for each patient that came, I'd definitely be a billionaire. For every patient that comes and says, I feel like I'm addicted to these medications. I feel like I need it. Okay, yes, there is definitely addiction out there, but don't ever call yourself an addicted person unless you look up the definition of addiction. Dependence is very common. Your body depends on it, unfortunately, physically and emotionally sometimes, because it's sort of like your release of stress, pain, or whatever it is that the opioids do. Dependence is when you need it, and your body, if you don't take it, feels that sort of maybe withdrawal or just the sensation of anxiety. That's dependence. Addiction is when you're taking it for emotional support. When you don't have pain and you're taking it because it makes you feel better. It's a very blurry line, by the way. I can't even diagnose my patients with addiction unless it's like red flags. Otherwise, it's very hard. And then the side effects and the tolerance is when you need more and more as time goes by. And that happens pretty much all the time, which is my least favorite part of opioids. And that's why you need other medications besides opioids, because they can help to improve the efficacy of opioids. Side effects of opioids is also horrible. I'm going to go over that. Short-term side effects, euphoria, which is that high that some people feel, pain relief, drowsiness, and sedation. You hear all these people that overdose on prescription medications. Some of it is not on purpose. Some of it is because their pain is so high, but unfortunately the side effects people don't build tolerance to. You stop breathing, you stop really, being alert, and unfortunately that's when people don't breathe, and then that non-breathing gets you even more comatose, and that's what's bad about it. But of course, if you take it as your doctor has prescribed, you shouldn't have that issue. These medications, each time you take it, it takes about 20 to 30 minutes to actually kick in. So if you don't feel it in those 20, 30 minutes, don't give up on it yet. Wait about an hour before you take the second dose, if you're allowed to. Then the sedation part is what you want to worry about. Now, long-term side effects is the one that I said, it's okay if something new has happened, you can take it. Long-term issues is prolonged nausea and vomiting. You can actually get abdominal issues. You can actually get constipated and cause obstruction, needing surgery sometimes, and hospitalizations often. Liver damage because of the Tylenol that's in it, and memory issues. And something called hyperalgesia, which is to a painful stimulation, you have more pain. If someone pinches me, it's painful, but if someone is on opioids for a long time and someone pinches them, it's very painful. And that's where the problem comes in when people who have had chronic pain and they're on chronic opioids, they come and have surgery. It's every doctor's nightmare because we cannot control their pain, especially if they're on a high dose of opioids. We're trying to change that and having the patients to go down on the medications so that when they have surgery, let's say, cancer patients, they've had radiation chemo before and they're on a lot of opioids and now they have to have surgery. You want to try to decrease that before the surgery as much as you can, because then your pain control after surgery is a lot easier. All right, this is my favorite type of medication, neuropathic medication. So opioids was one, neuropathic medication is the other one. There's many of them out there and different category of medications. One of them, the first one, probably most patients who have pain go on is gabapentin, which is an anti-seizure medication. So I explain it to my patients like this. Anti-seizure, that means it decreases activity everywhere, including your pain receptors. So unfortunately, it comes with the everywhere else too, which is the brain. So the side effects, you can get a little drowsy. You can feel like you're kind of out of it. It's not a permanent change. When you stop it, you get back to the way it was. But it is a great medication because not only does it help nerve pain, it also helps anxiety, which most of us end up having when we go through something like cancer. And so you want to make sure that, if you're on it, you take it slow, you go up slowly on it. And then there are other medications in the same category as gabapentin, like Lyrica, Topamax, Lamictal. There's all of these other ones that help with nerve pain. And the other bad thing about these medications is weight gain. So sometimes when you're going through chemo, maybe it's not such a bad thing, because I know a lot of my patients actually end up losing a lot of weight. So maybe that's not so bad. Then there's the second category, which is the antidepressants. There's many categories in the antidepressant category, but there's two that work really well for pain. My favorite one is Cymbalta, which is an SNRI. So there's the SNRIs, which is Cymbalta, and it works pretty well. It works well for not only pain. What it does is it works through the brain, but it also helps your anxiety and depression. Some of us don't realize we're depressed, but most of the time when you go through something like neuroendocrine tumor treatment and just the idea and the diagnosis, it can be very hard on us. So it's not a bad idea for us to go on these. And it doesn't mean you have to be on it permanently. Maybe it's temporary until you feel better, and maybe get a little psychotherapy and a little bit of activity in, and then you can come off of it. Now, the other category is called tricyclic acid medications, which has amitriptyline, nortriptyline, And those two are used often too. Those come with a little more side effect because they work through 3 different receptors. But most of the side effects is drowsiness, changes in mood, usually for the better. But initially, for the first week or 2, there is a transition stage where people feel maybe a little jittery, maybe really drowsy, maybe very down. But all of these, you want to make sure you have support when you start taking them. And then the other bad thing about it, or the other good thing about it, is that you get basically improving your pain control. All right. The last thing I'm going to talk about is the procedures that I can perform for these for the pain. There's many procedures out there, but the ones that I think are more relevant for us today, the first one is celiac plexus block. There's 3 different types of blocks that we do for the the inside, basically visceral pain. Celiac plexus block, hypogastric, and splanchnic nerve block. Celiac plexus is probably the most commonly used. If you have that gnawing pain that's like sort of in the abdomen, in the epigastric area, usually comes from the pancreatic issues. What we do is, as you could tell, there's needles that go in your spine. There's different ways of doing it. Some doctors do it through endoscopy, so they go through the mouth, and the GI doctors can do it through the stomach, and they numb the nerve. So what we're numbing, there's a thing called sympathetic chain of nerves. And the sympathetic nerves are really associated closely to pain. We're still trying to figure out exactly why, but we know that they are. And when we treat it, it helps. So by numbing those nerves, it decreases the pain. And so that red thing with the A is called the aorta. It's a very big, important structure in our body that gives blood supply to the rest of our body. And what we do is the nerves are right around it. So we can do it. This one is showing the CT guided one. Some people can do it through x-rays as well. So what you do is you go through with a needle in the back by the aorta. There's different ways of doing it. There's a needle that goes right through the aorta. It's thin and gets to the front. And then there's another one that goes around. And both of those basically block that sympathetic one. If it's going to be something chronic, they use alcohol to basically burn the nerve. The good thing about this block is that you get good pain relief. The efficacy is pretty high. The bad thing is that the pain can come back, and if you use alcohol, it can actually make it worse and then get better sometimes. Now, there's another one. So let's say you have like a surface of the abdomen hurts. There's a thing called TAP block, transversus abdominus plane block, and that's a pretty simple procedure. It's pretty low risk. You just numb the nerves that are going across the belly. It's between the 2 muscle layers of your belly, and that numbs those nerves. Sometimes it helps actually pretty good for a good time. So this is the most important slide, I think, here. How do you treat the pain? Social support, family support, positivity, and extracurricular activity. Just make sure that you don't forget you're not alone when you have these pains. It's not just you. It's frustrating. It's normal. It's okay to be sad. It's okay to be angry. It's okay to have all of those emotions. It's normal. You can go through it, and make sure that if you have a loved one, you try to let them know that this is the reason I'm feeling this way, rather than just reacting. Because when your loved ones know why you're reacting away, they're much more understanding of it. So keep your family support close to you. Talk to them. Let them know how you're feeling. Let them go through the emotions with you. It's okay. Don't feel guilty. They want to be there. Otherwise, they wouldn't. And that's it. You're not alone. These are my references, and thank you. The question is, recently diagnosed and not sure why all of a sudden she has pain on her wrist and it goes away the next day. Sometimes on her breast, the next day it goes away. And if anyone else has ever experienced this and whether that's normal. I'm going to ask, is it a hormone release? If you don't have to answer. It is, okay. And is it okay if I ask you what kind of hormone?
Yeah, in fact, when I first came in, I had real high serotonin level, like 800, 700. and I just got serotonin down to 150,
Okay.
which makes me really happy. But I can feel a big difference.
Yeah.
So,
So,
that was.
I'm not good with the numbers. It's not my specialty, but that's a good thing. I know. So basically, it's a serotonin releasing hormone, or cancer. And why is it? It's a good question. So yes, the problem is most of the time we don't know why.
Okay.
The good thing is it goes away. Sometimes, again, there's definitely probably some pathological, there's something going on, but sometimes also being aware of the fact that you have something, you become more in tune with your body. It's a good thing and a bad thing. Have you talked to your doctor about it?
Not yet.
Okay. I would talk to them because I know, again, it's a very little amount of knowledge I have, but I think carcinoid actually can be painful. There's certain symptoms, right? It can cause pain as well. So I would talk to your doctor to see what it's about. And then sometimes you just need to, unfortunately, live with it until you get the treatment and see what happens.
Thank you.
I wish that everybody was here that could answer whether they've experienced this or not. I wouldn't know.
Okay. Thank you very much.
Welcome. So the question is, she has talked to her she doesn't know whether the pain that she's experiencing, it's hard to talk to her oncologist because she doesn't know if it's the treatment or the actual disease process itself. That's what you mean, right? And how do you differentiate the two? How do you talk to your doctor about it? I guess it depends on your relationship with your doctor. The issue is a lot of times us doctors, we only focus on what's our specialty. And so you come to me for pain, I only want to focus on that. I have a little bit of more of a holistic thing though. I'm a big fan of diets, life changes, but that's not my specialty, that's just the way I am. It has nothing to do with my specialty. So what I would suggest is if you feel like the pain is really bothering you, ask your doctor to send you to a pain specialist. It doesn't hurt. You go to a new set of eyes. They might not know exactly what it's coming from, and they might never find out, but at least you have somebody else listening to it, and maybe they can come up with something else they could do. Again, if the pain is the same pain as you had when you had if it started after the treatment, most likely it's something different. If it was the same pain as before, then maybe it is the cancer itself that's causing some issues. But most of the time, I think it's the nerves that are just misfiring. But I do think you should ask for a consultation or a referral for a pain specialist. There's so many of them out there, and you definitely want to go to one that is more of a holistic approach. Just because, good or bad, us doctors, we want to just quickly fix things. And so a lot of times that's not the solution. And figure out what's going on. I mean, if you want to talk to me afterwards, we can be a little more specific as to what's going on. But acupuncture, acupressure, chiropractors, those all go sort of in a different category of pain management. Not a big fan of adjusting in chiropractor, but manipulation is wonderful. Like, let's say you have some issues, back issues, or whatever it is, it's okay. But acupuncture and acupressure are wonderful. It's not exactly my specialty again, but what acupuncture is supposed to be doing is it's Eastern medicine, right? They have these pathways as to how your body's pathway is. They can actually pinpoint areas. Like, for example, there's like 3 or 4 points in my wrist that associate with something completely different on my body. One of them is for nausea. The other one is for headaches. I'm just making this up, by the way, as I go. But acupuncture is wonderful, but you have to make sure you go to the right person. So it can treat chronic pain. It's actually part of the multidisciplinary pain management, and I love acupressure and acupuncture. If you find a good person, is the way to go. Because if you just go to anyone, they might not know exactly what they're doing. I always make fun of the fact that I tell them, I'm like, did they actually get their training somewhere, or like somewhere that knows how to do acupuncture, or did they just go to one of these like online, whatever it is, or some schools? If that's the case, don't go to them, because it's like a, I don't know, there's a spiritual aspect to it, and they have to really know what they're doing. So if you have chronic pain and you want to give it a chance, I definitely encourage you to do it, and make sure you go to someone that's good. Otherwise, you'll get discouraged. And the needles are very, very, very small. I haven't done it yet. I'm scared of needles. But my colleague has told me that I won't even feel anything. I just haven't had enough pain for me to want to go through it. But I definitely encourage it, really, really encourage it, because I've seen great response to it. Acupuncture can help with anything, nausea, headaches, chronic pain. It can actually help with your metabolism. It can help with constipation, diarrhea, any of those. I'm not sure how it can, but it does. So I really recommend it. Sorry, the question was, how do you find a good pain doctor and a good acupuncturist? Referrals, I think, is the most important thing. But most of us, aren't fortunate to get referrals. So what I suggest is go with your gut feeling. I always tell people when you meet, it's like when you buy a house, right? I haven't bought one yet, someday soon. But you go to a house and you get a feeling. You say, I feel like I want to be living here. You go to your doctor, either it's your oncologist or pain doctor. If you don't get that good feeling, even if they're great doctors, it's not going to really go that well. It could be better if you get somebody that you really feel comfortable in that connection with. I believe in something more than us. So there is something that connects us to people, and there's something that's in healing with people that we really bond with. Acupuncturist, usually pain doctors that believe in multidisciplinary pain management, they should know some acupuncturists, unless they're new in the environment, which was me actually in Thousand Oaks. But the best ones are usually the ones that aren't as advertised. I always say it's like a hole in the wall usually, and they just practice what they love. But I'm sure there's exceptions to that too. But yeah, I don't know how to find a good one. Training, where they got their training, is a big one. So see, where they got the training. And then for the pain doctor, look at what they advertise. If you go to their office and it's, again, nothing against my colleagues that do, but it's all about procedures, maybe you want to do something different. The best practices are the multidisciplinary pain management practices. I don't have one myself, so I shouldn't be saying this, but you want to go somewhere that has the whole system covered. Those are usually the best, where they have a psychotherapist, they have a physical therapist, they have an acupuncturist in the same setting. Those are just very hard to find because medicine is very difficult these days to succeed in. So, yeah, so the point was, thank you for letting you know, that sounds weird, that we can ask for a referral for pain management docs, and that it helps a lot to know that. Actually, UCLA docs, I could tell you, they're very good at that. I get a lot of, it's not my specialty, and I have told them, I'll do my best, but our UCLA oncologists, they're very good at trying to reach out to us when they think that they're not doing a good job. So yes, definitely you have the option, and insurances approve it. So it's good. So the question is, how do you treat bone metastases from neuroendocrine tumors? It's a very, very difficult treatment to do. So any procedures that you do. So usually when you get bone metastasis, it's pinching on the nerve a lot of times that's causing pain. And sometimes just the actual mets in the bone really hurt. Osteoporosis hurts, so I can't imagine a mass in your bone. So the treatment is pretty much the same thing, except if you need to do a procedure, you're taking a risk of actually spreading it further. Because when we use a needle, that needle can be the source of spread as well. So unfortunately, or fortunately, I'm not sure which one again, because maybe it's a good thing we don't just do procedures on that. But unfortunately, there isn't any other treatment for it. If the pain is coming from the mass itself, they have to remove it. Neurosurgeons remove it. If the pain is coming from, the pinched nerve, they could also remove it and help that. But if it's a lot in the different places, radiation and chemotherapy should help that pain. But then they come with a price that sometimes you get osteoporosis from all those things and inactivity. So if you can, the more you use your body and move it, the better it is for you, because you don't want to get to that point. Every single patient that comes to my office and they have some sort of an inflammation going on, I put them on a gluten-free, dairy-free diet. They hate me. But 50%, I'm really convinced it's 50% of them say it has helped. I don't believe in, oh my God, it's a Hollywood thing. I actually do gluten-free myself and dairy-free, but it's a pretty miserable life because you can't eat cheese. But I can say that it has helped me as well. And not only do you feel with more energy, I do think that most of us don't really metabolize gluten well, and dairy actually feeds into inflammation. So by do a 2-week trial of gluten-free, dairy-free, and you can't cheat, because as soon as you take that one bite out of that really tasty bread, it goes back to square one. And nowadays, it's so easy to do gluten-free and dairy-free because there's all these other options. I actually don't like processed food either, so that's why it's such a miserable life for me, because I don't eat anything processed, because I think all processed food come from these horrible things that they put in our system. And then organic. Organic is super, super expensive, but like animal products, I highly encourage it. Fruits and vegetables, I don't think makes that huge of a difference if you can't afford it, because it is very expensive. I don't do it myself. But dairy products like milk, eggs, all those should be organic. I think it makes a huge difference. And then there's other supplements you can do. So if you love to really go all out, you can make your own turmeric juice. They sell turmeric pills. I don't think they work as well. Man, I'm going to have a lot of companies coming after me after all this talk. What? Turmeric pills work? So they do work, definitely. So alpha-lipoic acid, turmeric, of course, all these you got to talk to your oncologist about it to make sure that there isn't any issues. But turmeric really works. So what you can do is actually bake your own turmeric. Please be careful. It makes everything yellow. But you can mix it with coconut milk and drink it every morning on an empty stomach. Not only does it help you with your body's basically immunity and anti-inflammation, but it's good all around. The other thing that for anti-inflammatory is stress. Decrease your stress. Inflammation and stress go hand in hand, and so can certain foods. So try the gluten-free, dairy-free diet for 2 weeks. If it doesn't work, go back to your normal life. And then add the turmeric and alpha-lipoic acid. I always tell my patients, whatever change you make to your life, stick with it for 2 weeks before you give up on it. And then wait to start a new thing. So don't start 2 things because you don't know if you could have maybe had that really tasty cheese and you just needed some turmeric.
On the turmeric, how much would you?
So the bottle has different. So there are some places that give you a very high dose of turmeric. What I usually do with the turmeric is I actually just the roots. You can buy it from Sprouts, Whole Foods, every advertisement, man. So you can buy it and bake it. Basically, one root can carry you for about at least a week. So you basically mix it with a little coconut milk and you drink that. It's pretty good. Yeah. And if you want to make it tasty, you just put in your food. You can always add turmeric to every food you have. You just have to make sure the turmeric is real turmeric, not just. So the question is, what is the use, or what is the medical marijuana? Okay, it's a very personal question, I think. Now that it's legal in California, you can get it anywhere. I could tell you the studies that have been done. They're not by the FDA, most of them, or any of them actually, because it is not legal federally. And so the results are pretty good. Here's the issue with it. I'm a big fan of the non-drug life. So it depends on who you're speaking to. I'm not against marijuana, though. I have a lot of patients that use marijuana. And, they do either the drops, they do the oils. So the oils are topical, CBD oils. What CBD is they took out the THC. So THC is what makes people high. They take out the THC from marijuana, and what they're left with is CBD. And the problem with it is there is no regulation on it. So what you get from one place could be very different than what you get from the other place. And you don't really know what the purity is, and you don't know what exactly it has in it. But that said, I always encourage my patients, in case they want to try it and see if it does help. If it helps and you're taking much less of the other stuff, why not? The other stuff is not that much better for you anyways. So I'm not against it. And the response to it is not 100%. So I have maybe 60% of my patients, maybe even less than that actually, that don't really like it, and then the other ones that really do like it. It does increase your appetite, which is wonderful, but the other symptoms, I think either psychologically people don't really like the feeling of it, or it doesn't work. I'm not sure. So I think it's worth trying if a patient is at that point where they're taking all these opioids and they're like, you know what, I want to try it. I definitely encourage them to do it, because I do think it might possibly be better than opioids. So the question is, TENS unit is microcurrent, is similar to it, and then myofascial massage, is it the same thing as physical therapy? Okay, so try anything. If it doesn't harm your body, it's not the same concept as TENS. It's a little different. But I do think it's worth trying. I've heard good results with it. There's so many different treatments out there. And then there's like a myofascial release, which works really well too. And I do encourage my patients. I actually have a guy in Malibu that does a really good job with it too. It's not this, so it depends on which physical therapist you go to. Physical therapy is very vague. It's got a big category. You get some physical therapists, all they do is just strengthening exercises. You get another physical therapy that literally just like dabs you on the back and puts a TENS unit on. And you know, you can get any range, but there are some physical therapists that do myofascial massage and they do myofascial release. I have one that I truly love. Actually, I have two by my area, and I think very highly of them, and they do a combination of everything. But yes, it's definitely a great thing to look into.
Is that something that's for the myofascial for scar tissue?
Yes. Scar tissue, another thing that's very good for it is ultrasound therapy. Mm-hmm. You can try it. There's some good response to it.
And then my other question related to the same field is the low laser light therapy with like the infrared.
Yes, at physical therapy places, you're saying?
Yeah.
So the question is about infrared light. I don't know enough about it, but I know the physical therapy that I work with, they do have it and they use it. They've had good response. Okay. Again, it depends on where your pain is, what's the origin, and whether you respond to it or not, and who's doing it. Okay. But I always tell people, you have nothing to lose. To try it at least. Yeah, of course. Any other questions? Okay.
We're going to have a brief presentation from two patient navigators who are with us today from UCLA. And I have to say, I was a new patient at UCLA last year, and while I was sitting in the waiting room, someone came up and introduced themselves and said, "Hi, I'm the patient navigator. Let me tell you about all the things that are available to you here." And I was shocked. I had no idea that such a program existed. So I think they're here to help us learn more about what these resources are and what's available to us. So please welcome Michelle and Consuela.
Good afternoon. So, as Giovanna said, she came into the 2020 Hematology Oncology Clinic and did not know that this patient navigation program existed. It's only been in existence since 2011, where when I was actually hired, and so I've had the opportunity to build out this program, and the position was basically centered around what the patient's needs were. So if a patient had questions that were of a non-medical nature, non-clinical, because none of the patient navigators are clinical in any form or fashion. So these are all issues that may be frustrating or causing concern, causing any kind of anxiety, and we are there to relieve these stresses. The patient navigation program is basically designed to identify any issues and any concerns and address them in a timely nature. So we're there to share a lot of the resources that we have, and I don't think a lot of people know that I've gathered a lot of these resources since 2011, and with also adding additional navigators. We have 4 at the 2020 clinic just because it's one of the largest clinics out of the clinics that we have. So obviously you can imagine that we are getting a load of patient issues on a regular basis. And some of those issues are as common as needing transportation or accommodations for patients who live out of town. Also home health services or care nurse. There are also issues with insurance and billing issues and odds and all those things that cause a whole lot more stress to the patient than they need while they're trying to care for themselves. And it doesn't matter who your doctor is, it doesn't matter what cancer you have. We're there to assist all of the patients because we are stronger and are able to get to the point of where you're trying to get without you having to do the extra work. And then we also have to enlist a lot of the departments. The 2020 UCLA Hematology Oncology Department has a lot of departments within that clinic. So if there is a need for an urgent doctor's appointment, or if you need to reach out to your doctor and you've been trying for the past couple of days, well, you would reach out to the patient navigation department and the patient navigator will get to your doctor immediately. We also are dealing with patients who are having treatment and then recovering in their car. So we're dealing with homeless patients. We're dealing with patients who don't have any food. And so because we've gathered all of these resources, and you don't necessarily have to meet us the very first day, but we meet every single patient that comes in. But also if you're having a discussion with your doctor and the doctor, and you share something with the doctor will reach out to the patient navigation program to let us know, well, okay, this patient is having an issue. Can you come and talk to them? And the same with the call center. I know Kathy was saying there's only one number to get in contact with anybody at our clinic. Well, when you meet the patient navigator, you get our direct number, so you don't have to navigate your way through the actual call center. But if you do call the call center and you have any urgent issues, they'll connect you to a patient navigator. The nurse practitioners will put you in touch with us. If you walk in for an appointment and you walk in with an issue, the front desk is going to put you in contact with us. So we're there to assist so that, again, there is some relief while you are trying to get better. As well as there are also issues that we deal with because, like I said, it is an emotional disease. There are patients who I may speak to on the phone and they're so distressed and they're crying, or on the opposite side of that, there may be patients who are angry and they're venting. Well, of course, we're there to calm those situations and try our best to resolve the issues. So again, we've built up an enormous amount of resources so that you don't have to do the work. We're there to do the work, and you know, we also want you to know that there is no loss in humanity when you're coming to our clinic, because we are there to help you. And it's interesting that a lot of people don't know about the program, but that's why we are introducing ourselves. I mean, the Santa Monica Clinic sees about 1,000 patients a week. So obviously you can imagine that there are a lot of issues on a regular basis. So yeah, we're sometimes our hands are tied. Sometimes the concerns and issues are extremely challenging, but we're going to go the extra yard, and we're not going to stop until someone tells us to stop. But we know what the needs are, and we know what the patients are going through. So yeah. I also, I mean, you know, again, the patient navigation program is only as strong as the navigators that work within the program. So they're hardworking, they're dedicated, they are committed, and they are willing to go the extra yard to try to make sure that your issues and concerns are addressed. And Michelle is one of those people who I've had the opportunity to work with. She's been part of the program for about 2 years. Took me a year to find her, but I'd like for her to share from her perspective some information about the patient navigation program.
Good afternoon. My name is Michelle Barton. I've been with the Hematology Oncology Department in Santa Monica for almost 2 years. I have a different story because I've been on the other side. I've been a patient who's been diagnosed, and on the first visit, alone and not knowing what to expect. So I come with a different sense of empathy and also experience. So some of the things that I would say is that don't come alone. Always bring writing materials or a recorder so you'll know what the doctor said, because sometimes it sounds like Charlie Brown, womp, 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 womp. And then you get home and you don't know what's going on. So I would always say, bring someone. I would also always say, write down your questions before coming to your appointment. I would also say, have a contact person, either your nurse practitioner, your doctor, or in our case, you have a patient navigator who is, it's a team of people who are willing to help you. So Kathy, you will leave with numbers and cards. So your next visit, we're here to help you. The idea is before a problem becomes a crisis, you have a contact person. So know that you're not going through it alone, and we're here to help and support you. Mm-hmm.
Thank you, Dr. Ronald Reagan. Is that same service available there? Because I have never heard of you before. Can you repeat the question?
So the question is, I'm seeing a doctor at Ronald Reagan, and I've never heard of the patient navigation program. Unfortunately, we're only at Santa Monica. Maybe if you ask more, we hear that's in the pipeline that it'll be at all of our 14 clinics, but it's a service that is in Santa Monica now.
Now, if you want to get information, case in point is I went online to get some medical records. So is getting medical records from Ronald Reagan the same as getting them from Santa Monica? Is it all for the UCLA system, or is each one handled differently? Because when I went online and said, okay, download this form, fill it out, send it in, did that, didn't hear anything. Finally called in about 2 weeks later and said, when am I going to get this? And they said, oh, you filled out the wrong form. So, well, it was online. I said, well, we don't know what to do about that. So I don't know whether that's just specific for that specific hospital, or is it through all of UCLA?
It should be throughout all of UCLA, but Consuelo can direct.
So I believe the system with medical records has changed a bit. With the 2020 oncology clinic, the records were right at our disposal. Now I guess it's all compartmentalized, and you have to get the records specifically from Ronald Reagan, and that's for all the departments. I mean, they're not even printing out paper records anymore from each individual clinic. So yes, at the moment, Ronald Reagan and you can put a urgent or stat, because if you need those medical records for other doctor's appointments, yes, you need to let them know. And again, I mean, I understand that you are going to Ronald Reagan, but I would even be willing to assist you if you have any issues that are again, like this particular issue frustrating you, and because a lot of the times when we make a call, a lot of things get done a lot quicker. So if you need that assistance, we're there to help you. Okay? Any other questions? Hi, Kathy.
Kind of a generic question. If I ask my doctor, can I have a printout of the visit summary for the last visit? Is he allowed to do that?
Once he signs it,
Will you repeat the
yes.
question?
Oh, so the question is, if the doctor does a summary for that visit, are you allowed to receive a copy of it?
From him?
Yes.
Or
So,
is okay?
yeah, I mean, so usually the doctor's summary needs to be signed, and there's a possibility where the doctor may not sign it that day, or right after your visit. So, but once he does sign it, or the nurse signs it, then it'll be, and you did say that you were a part of the myucla.org portal.
Yeah.
So if you request that summary, there's not a problem receiving it.
Okay.
Okay. Any other questions? Hi.
Hi. So we've been going to 2020.
You look familiar.
No, we've been going there for 3 years and
Yes.
have not ever heard of a patient navigator.
Wow. Yeah. So have you had any issues? Because a lot of the patients who don't have any issues or concerns, then they would necessarily be put in contact with the patient navigators.
So who is the one who connects patients to the patient navigators? How do we get access?
Well, so if you come into the clinic and you ask the front desk, may I see a patient navigator? They'll call one of us out. If you have a meeting, a consult with your physician, and you're discussing an issue with your doctor, he'll say, oh, well, let me contact one of the patient navigators to help you. If you call in and there's an urgent crisis from the call center, they'll connect you to us directly. So, and a lot of times there are patients, because they don't have any issues whatsoever, they're never put in contact with us because we're there for crisis situations for the most part. Yeah.
And now we're seeing most of the new patients in counseling.
Yes, so we are seeing pretty much every single new patient that comes in and every new consult that comes in, and we introduce ourselves. We give them our cards. Our numbers on our cards go directly to us, and so you speak to us personally. You don't have to, be on the waiting list for 10 or 15 minutes to try to get through. So you'll reach us immediately. Okay.
Thank you so much. Thank you. I feel like we just had two angels visit us. Thank you. This is really so important, Consuela and Michelle. I think lots of neuroendocrine tumor patients had no idea. So we'll talk with you about the best way to communicate how patients can reach out to you who are patients in that building there. So thank you, everyone, for coming, and thank you for joining us online. We look forward to seeing you on February 13th if you're in Los Angeles at Cedars-Sinai. And thank you so much for your support.